Waiting for Dr. Deepak Gupta. He said he is joining us. Ganesh, has he joined? I can't see Dr. Gupta.
Not yet, ma'am.
Oh, okay. Dr. Gupta, you're here. Should we begin?
Yes, join, ma'am.
Yeah. Dr.
One
Gupta,
moment.
good evening.
Good evening. How are you? Sorry to keep you
No.
waiting for a couple of minutes.
No, it's okay. All right. So should we start?
Yes, please.
All right. So good evening, everybody. A very, very warm welcome to everyone who has joined on the Zoom here and to the others who are joining through the Commonwealth YouTube and the Mohan Foundation YouTube link. We bring to you this masterclass in association with NATCO, which is the Alliance of Transplant Coordinators of India. And we're also happy this time to be partnering with the Commonwealth Tribute to Life, and we're hoping to do many more such webinars going forward. The webinar today is on pediatric organ donation. Pediatric organ donation, as we all know, refers to the process of donating organs from deceased children and even infants to save the lives of other children who require organ transplants. But we also realize that it is a complex process and comes with its own unique challenges, both medical and emotional. And in this masterclass, we'll look at pediatric organ donation from all these lenses. We have some very good speakers here. We have Dr. Deepak Gupta, who's a professor neurosurgery at AIIMS. I've had the privilege of working with Dr. Deepak Gupta over the last year or so in the process of organizing training workshops for other All India Institute of Medical Sciences and other government hospitals, helping them start their transplant and organ donation programs. And I have seen I've seen the passion and the sincerity which he brings to this whole process. In fact, he has his fair share of experience with pediatric donations. And I think, if I'm not mistaken, his first donation was a child. I'll, of course, leave it to Dr. Deepak Gupta to share that with you. We also have with us two very senior transplant coordinators, Dr. Navdeep Bansal, who's been with the PGI MER Chandigarh for many years now, doing some very good work. And we also have with us Mr. M. Shivakumar, who's the head of the Multi-Organ Transplantation Coordination Unit and the Medical Social Worker at the Rela Institute at a medical center. And they will come in later to share their experience. So speaking with families where the death has been with the child, that the deceased has been a child or an infant, and what it meant to speak to families for organ donation. But let's begin by having Dr. Deepak Gupta come in, speaking to us about pediatric organ donation. Over to you, sir.
All right. Thank you so much, Ms. Pallavi Kumar, for giving me this opportunity in the Mohan Foundation and the Allied Partners. I think in our country, we are gradually reaching a stage wherein the number of organ donations from adults are definitely increasing. But I see that there is a lot of existing knowledge gaps and lack of certainties in pediatric donations in our country. In fact, you'll be surprised. As of today, while I'm talking to you, large number of clinicians, which includes neurosurgeons, neurologists, they're not even aware that children can donate organs. They're not even aware that children are there are a lot of children who are waiting in the recipient list for the various organs. Trust me, majority of the people believe that it's 18 to 60 years age group wherein the donation can actually be done. So there are a lot of existing myths, kind of knowledge gaps, which I will try to address in the next half an hour. So please feel free to stop me if you want to take a break, and I'll stop because sometimes it becomes quite monotonous. So I'll share my screen. One moment. Okay, the screen is full right now.
Yes, sir, it is.
Okay, so I will be primarily focusing my discussion on protocols of brainstem death certification and challenges in children. Remember, we are talking about India, and in India, we talk about the concept of brainstem death, both in adults and children. We are not talking about whole brain death, which is being used in the various other countries. I'll be restricting my focus primarily on the brainstem death certification, which we follow in our country. I would like to dedicate this talk to this young girl, which Ms. Pallavi Kumar was just referring to. Her name is Roli. She was a brave girl. She died when she was in her sleep. So somebody shot her while she was in sleep, aiming to shoot her father, and she sustained bullet injuries in her head. Was brought to our center after 4 hours of injury, and somehow, despite the best resuscitative efforts, she could not be revived. Parents were illiterate. They had no idea. They had never heard about organ donation for adults or children. But subsequently, when we talked to them in detail and explained about the need of the organ donation and possibility to save many children, both father and mother unanimously they agreed. And she went on to save almost 4 lives, and she gave vision to 2 more children. And so she's the first pediatric donor. I had a 6-year-old girl at that time last year, and subsequently we had more donations, taking her as an example. So whether it's an adult or a child, let me make it very, very clear. Diagnosis of brain death is a clinical diagnosis. You don't need any test whatsoever to diagnose brain death. You just need some working neurons, a thinking mind, and an aptitude and a knowledge that, to be able to reach to a clinical diagnosis to diagnose brain stem death. So it's fairly easy, provided you know how to do the various tests in a very coordinated fashion. Most important thing is the coma and apnea test, they must coexist. So the person should be apneic when we do some test or give some respiratory stimulus in the form of disconnection from the ventilator, and the person has to be comatose. Naturally, we need to do the testing for the various neurological functions, which is called as brainstem reflexes. They need to be absent. Tests, they need to be performed in the setting of normal age appropriate physiological parameters. By this, I mean, you know, in an adult who is around 18 to 60 years of age or 70 years of age, blood pressure, we always say that 130 to 140 systolic is the normal blood pressure in the person. So in an adult, even if the systolic blood pressure is more than 100 millimeter of mercury, we take it as fair enough. But if you have an infant, let's say 1 month infant, and his or her blood pressure, if it is 70, that is fairly normal because of the age of the child. So you have to take those age appropriate physiological parameters. Then the other thing which is very, very important is there has to be a known cause of coma. You know, if you have somebody brought to you in the emergency in a comatose condition, there could be nth number of causes. You just don't jump to reach a diagnosis of brain death in that person. If you have a history of trauma, road traffic accident, so you have a known cause. Okay, if you have a history of hypoxia or ischemia or a stroke, you have a known cause. But if you do not know the cause, please think twice or thrice, in fact, multiple times before jumping to diagnose brain death in this person. The condition should be irreversible. That means there should be no chance for the condition to come back. And how do you say that? By doing a CT scan, which is the investigation available at all the level 1 and level 2 trauma centers and some level 3 trauma centers. And majority of the high hospitals in our country. Then you have to do a complete neurological examination, which is a mandatory thing. The examinations have to be conducted 2 times. There are certain countries wherein you do 3 tests. Some countries are asking for doing tests only once. But let us restrict ourselves to what is there in the guidelines laid down by TOTA. So we do 2 tests at various time intervals. I will talk about it. And the most important thing is all components of the test must be appropriately documented. The problem comes when you do the test and you do not document, or you do the documentation later on, and by that time it becomes very late. Sometimes it so happens even in the form 10, when 4 people are supposed to sign, let us say only 2 people have signed. The patient attendant may take a picture of that and may say to the rest of the group or the rest of the media and other people that the 4 people were not present during the test, and this can be a big setback to the program. So you have to protect yourself and you need to document the test appropriately. So these are the causes of coma which I was talking about. They need to be excluded. Patient should not be having an alcoholic intoxication. Patient should not be having some depressant. There are many drugs which are given to the person. Person could be on some drugs, opiums and other things, or he could be on some muscle relaxants, midazolam. So by default, we say that the 5 half-life of the drugs should be elapsed before considering brain death certification. Person should not be hypothermic, because we know that any person who becomes brain dead, he becomes hypothermic at the end, because the hypothalamus fails, so you become hypothermic, hypotensive, and you develop diabetes insipidus. The person should not be in shock, and he should not be having major electrolyte disturbances, especially more so the sodium has to be more than 125 or less than 160, and serum glucose should be in 50 to 300 range. These are the important things which have to be kept in mind. Now, sometimes you must have heard of some stories, some newspaper articles saying that, oh, this person was wrongly diagnosed brain dead and the person woke up and remained to live for many, many months and years. I think no patient has ever recovered from the diagnosis of brain death if it is correctly and appropriately done and documented. Let me make it very, very clear to you. Recoveries from the brain death, so-called brain death, they happen only if there's a premature discussion of the brain death by the physicians with the families, if there's a premature discussion with the organ procurement teams or the transplant teams, if there's an inadequate assessment of the confounding factors. I told you, patient may be in shock, patient could be having some drugs, they have not been completely excreted from the body, somebody has not performed the apnea test correctly or may not have done 2 apnea tests, may have done false positive ancillary test. And sometimes, patient may have a respiratory drive and you may misinterpret it as a ventilator autocycling. It happens sometimes. And see, these are the common drugs I have listed here on the right side. Atracurium, clonazepam is very, very commonly given to the patients. Codeine, diazepam, fentanyl is being used. Midazolam is being used very frequently. So let's say if a person is on midazolam and fentanyl infusion, that means the half-life of midazolam is 6 hours. You have to wait minimum for 1 day. The person has to be on infusion of one particular drug. So all the drug has to be excreted from the body before you start evaluating that person for brain death. So this is extremely, extremely important. Please remember this. So who is likely to be a donor? Adult or child? As I told you in the beginning, the person needs to have an irreversible brain damage. And how do you document? By a very, very simple test, which takes less than a minute, I would say, which show the completely hypoxic or ischemic damage to the entire brain and the brainstem included. And this is called as a white cerebellar sign because cerebellum may be visible, but the rest of the brain is all black. Okay. So to repeat again, brainstem death is a clinical diagnosis. 2 tests have to be done at various time intervals. In children, we do it at 12 to 24 hours interval. In adults, we do it at 6-hour interval. And let me emphasize again, EEG is not needed in majority of the cases for brain death declaration. We need 4 doctors and consent is needed from the two parties. One should be a patient family member. You don't receive any donations from the unknown patients and if there is no consent from the family. So these are the various tests which we need to do in the patients. I'll come to that very quickly. Person should be in coma. Person should not be having a spontaneous breathing. His pupil should be mid-dilated or dilated fully, both eyes. Remember one thing, all the tests have to be done on both the sides, not just one eye. So pupillary light reflex has to be tested in both the eyes. You need to do the Dole sign head movement by moving the head on one side and then on the other side. Always remember when you're moving the head, I'll demonstrate the signs to you in the next video. You need to take care of the endotracheal tube. Sometimes it so happens that the endotracheal tube comes out while you are doing the Dole sign movement, and that can be catastrophic. So you need to do the corneal reflex on both the sides. Motor response has to be tested correctly. Gag reflex, cuff reflex, eye movements, and apnea test. Apnea test should always be done as the last test and as the end. And if there's any respiratory movement, if it is seen, then of course you say apnea test is negative. If there is no respiratory movement seen, after 8 to 10 minutes of disconnection with the PCO2 rising to more than 60 or above 20 than the baseline, then you say a positive apnea test. And this has to be repeated 2 times, 6 hours in the adults and 12 to 24 hours interval in the children. So the first, why we do 2 tests? The first examination determines that the adult or the child has met the neurological examination criteria for the brain death. Okay, and when you do the second test or the second examination, the second apnea test, it confirms the brain death based on an unchanged and irreversible condition. So this is the basic purpose of doing a second examination. In the time of brain death, we say when the PCO2 rises more than 60 on the ABG in the second apnea test, that is the time we write on the file, the person is brain dead at such and such time. So this rule holds true both for the adult and for the children. Now I will come to important deviations in the children. First, I'll be talking about which are the donors, pediatric patients who can donate. Then I'll talk about medical evaluation and the consent from the family issues. Remember one very important thing, neurological death in children is infrequent, but it is not uncommon. In fact, if you go to the intensive care units, even in the pediatrics department, not the neurosurgical department, you will see many children dying of hypoxic ischemic insult. So in case you want to pick up cases of potential or possible brain death donors in children, you need to visit the pediatric intensive care ICUs, the neonatology units, and of course the intensive care units of the trauma of each and every hospital. And I recommend each hospital need to have their protocols, how to proceed in a child who is comatose, and what are the criteria to be done, and the do's and don'ts, like I have shown in the chart out here. Now, this particular gentleman, Christopher Pallis, he defined the ABC of brain death. And he always used to say that the physiologically children are no different from the adults. And the argument is purely visceral and scientific. However, having said that, the pediatric guidelines, they may look very similar to the adults, but they're important things. One is the timing or observation. We always observe children for a longer period of time, let's say between 12 to 24 hours. The younger the child, more is the interval. If you look at the form 10 very carefully at the end, it clearly mentions subject to the assessment by the physician team. The interval can be prolonged, so it does not specify. However, as a rule of thumb, a child between 1 year to 12 years of age, you do it minimum 12 hours apart. And child who is younger than 1 year of age, I recommend you do it at 24 hours apart. There's a lot of deviations in this. Some people say up to 1 month of age, you can do 24 hours apart. And after 30 days to 18 years of life, you do it 12 hours. So it's purely subject to the discretion of the physicians. But for you, for all practical purposes, you remember, any child who is younger than 1 year of age, 24 hours, and child who is older than 1 year of age, 12 hours should be the interval between the two tests. Then use of ancillary tests has got some relevance in children. The reason being, at times, the clinical examination has got some pitfalls in children. I'll come to that in the next slides. Children may have some small eyes or difficult to do the corneal reflex. And as I told you in the beginning, if any of the tests you cannot do, you need to do an ancillary test. As simple as that. So there's a more uses of ancillary test in children at times, though not always. And you have to use the age-specific values. So there are only 3 deviations compared to adult. One is timing of observation, 12 hours to 24 hours. 2 is use of ancillary test. And 3rd is age-specific values. As I told you about the blood pressure and other parameters, you take it in the children. Now the question comes, who should do it? Well, if you ask me, ideally speaking, it should be done in the presence of at least a pediatric intensivist, neonatologist, pediatric neurologist, pediatric neurosurgeon, pediatric trauma surgeons, pediatric anesthesiologist with critical care training. This is preferable. But if you look at the rule, the Form 10 very carefully in India, it does not specify that. So, any clinician which is marked by the hospital committee, for the 4-member committee, they can do the test. So it is preferable to have a pediatrician, but it is not mandatory. If you ask me, at my center, though I am a pediatric neurosurgeon, I always call a pediatric neurologist. He may be knowing less than me, but he is a pediatric neurologist by qualification. So just to be on the safer side, I do call pediatric neurologist at my setup while I'm doing the brain death evaluation in very, very young children. The reason being, the implications for diagnosing brain death are of great consequence. Examination is conducted by experienced clinicians who are familiar with neonates, infants, and children. This has been documented widely in various publications available on the by American Academy of Neurology and by the pediatric journals. So, I had this query. If you look at on the right side, my WhatsApp conversation with a very senior member of National Organ Transplant Program. I asked him once, why do I need a pediatric neurologist? I'm a pediatric neurosurgeon myself. Okay, but my team, they said, no, we need to have a pediatric neurologist. Keep the air of the ego aside, and when you have somebody available, always call for to be around to share the responsibility equally. Though there is no such law. Now somebody asked me, a children less than 1 year of age, why the hell do you want to do this brain death evaluation? Are there any recipients waiting? I mean, can you transplant to a child who's 7 months of 8 months of age from a brain dead child? Actually, the situation is completely different. We have seen cases wherein the kidneys have been retrieved from a 1-year-old child, from a 39 days old child, from a 3-day-old infant. And those 2 kidneys together have been transplanted on young children and even on young adults also. So it's doable. And the beauty of children is that even the ABO incompatible hearts take up well, because the immune system is not very well developed in the children. So if you have a 6-month-old donor with the heart is good, you can transplant that heart to another child. He may not be ABO compatible even. This was beautifully documented by Laurie West in Toronto in 1996 and was a game changer. Lungs do well. There's a long waiting list of the lungs of the very young pediatric recipients. You can split the liver, and it has been tried in India in children as young as 8 months of age. And very young children, 2 cases, 3 days and 39 days old infants have been reported in our country, India itself, successfully. So you have to remember that irrespective of who will receive, just don't worry about where the organ is going to go. If you declare brain death certification in a very young child, a month-old child, or a year-old child, or a 2-year-old child, so I don't think age actually ever matters. All you need to be very clear is that you need to complete the brain death certification. So if you increase the brain death certification rates in children in your center, you're likely to impact the number of organ donations in your country a big time. So irrespective of who will receive, just don't worry about it. There are many people in the recipient team who are having expertise in our country to successfully transplant organs from the very young children. Now, what are the challenges? Let me come to now hardcore part of the presentation. What are the challenges you have in pediatric donations? One, the disease processes are completely different in children, which may cause neurological death. Many of the young children, they can have hypoxic ischemic insult. Many of the children could have battered baby syndrome. And of course, road traffic accident, we already know. Then there are wide range of patient age, because age group I'm talking about is between 30 days to 18 years. That's a pediatric population, right? Or maybe the newborn child. Sometimes people say 37 weeks period of gestation to 18 years of age. So there's a wide range of patient age. And naturally, all this it's a continuum, physiological continuum. And so those physiological parameters, pulse rate, systolic blood pressure, and other things will differ widely. There are some challenges with the apnea test, because sometimes you don't even have an arterial access. And if you don't have an arterial access, naturally you cannot do an apnea test. Am I correct? So it's not easy to put an arterial line in an infant. So it becomes an issue sometimes. People have tried to resolve it by doing ETCG, by venous blood sampling, but arterial blood sampling remains the gold standard. Then, of course, availability and the use of the NCD test. Many of the centers, they do not have access to, you talk about, you must have heard in the books, people talking about SPECT scanning for cerebral blood flow. How many centers in our country have got SPECT scanning machine available bedside or in the center where the brain death actually happens? None. EEG availability is again very scant in the trauma centers, and not many people know how to interpret. There are a lot of false positives and false negatives in the EEG. Then who will interpret this ancillary test to document? Sometimes parents and the guardians, they object to determine neurological death in the children. Sometimes the parents get very frustrated. If you tell them, oh, we have to wait for 24 hours for doing the 2 tests, they said, we don't want it. And many parents in the West, they say, bluntly no. There's a lot of fear and anxiety among the clinicians. At my center itself, many of the clinicians, I'm talking about the people who are supposed to be well-read members of the society, they feel so anxious and they have so much of fear that they are not competent enough to do the brain death certification. What if I do the brain death evaluation or certification wrongly? The entire onus will be on me. That is absolutely wrong. I think if we as clinicians, when we have done our MBBS, MS, MCH in various streams, if we cannot do brain death certification, which is a clinical test, we have no right to be called as a physician. So I think each one of us is competent. We just have to have the confidence, and we need to know what are the tests to be done. And of course, there's a lack of awareness. There is no doubt about that. So my personal feeling is the biggest challenge of pediatric organ donation is lack of knowledge amongst physicians or clinicians. Now, what are the problems with the children? There's a difficulty in visualizing pupillary responses. We have got very small pupils in the children. It becomes especially in the newborns, the pupil size is very small. It's like pinpoint pupils. You don't even know whether it's reacting or not reacting to the light. Sometimes the corneal reflex you may not get. It could be because of small palpebral fissure, or it could be because of dehydration. The corneal reflex may be less responsive. There could be massive swelling on the face, and so you just cannot do various evaluation to the corneal and the pupillary responses. And naturally, when you cannot do this test, you have to have the ancillary test. Sometimes the caloric response, where you put in the ice cold saline in the ear and look for any tonic derivation of the eyes, it may not be possible because the external auditory canal may be very, very small. Of course, we have to use lesser amount of saline while doing it in the children. And in newborns, the sucking and the rooting reflex is present. If it is absent, naturally it goes more in favor of a absent brainstem reflex. You just have to put your finger on the angle of the mouth, upper lip, lower lip, and the child turns his mouth towards you. That means the child is having a reflex positive. If no, that means the reflex is absent. Traction response, you give some sound, loud noise to the child, or some wisp of cool air to the child, or some air to the child. Child suddenly startles and moves the extremities. That's a normal response. If it is absent, that means the brainstem reflex is absent. There's a traction response. When you hold the patient hand, the child will move away from you. Try to hold your hand firmly. So Morose reflex again, tonic neck reflex. So these are the reflexes which are to be tested in very young infants and neonates. And people should know, those who are dealing with those organ test certifications. Apnea test is by and large same as adults, but of course you have to use the age-specific BP threshold. Then in the ancillary test, I would say that cerebral blood flow studies are better than EEG because they are less false negatives. By cerebral blood flow study, I'm talking about doing either a TCD or doing a CT angiogram. At our center, we have started doing 7-point CT angiogram in very young children. We have done it in I think 4 cases successfully, which shows absence of cerebral blood flow in both the middle cerebral artery, M3, M4, ACS, A3, A4, and 3 more vessels. Total of 7 vessels. If it is absent, internal cerebral vein and 2 more vessels, then we call it a positive CT angiogram or a lack of cerebral blood flow. So it is doable in the children, and you don't need to do a DSA shifting the unstable child for the digital subsection angiogram. The TCD sometimes has got transcranial Doppler has got false positive, because sometimes when you do the fontanelle compression, the fontanelles are open. There could be some false recording in that. I mean, if you ask me very openly, what are the total number of tests you need to do? A total of 25 assessments are required to declare a person brain dead, and all must be checked. You know, all these things are there in our Form 10 also, if you read it very carefully. So, you know, right from the beginning, I've told you about the prerequisites, about the examinations, and about the apnea testing, what all things to be done. You have to tick on each of them. And it's always best to have a document ready in your ICU, read at it, and start ticking it. And if you don't tick any of the parameters, then you have to do an ancillary test. It may look very simple when I'm making my presentation to you, but yes, it requires some expertise. And I believe that the neurologists or the neurosurgeons, they are best marked for these 25 assessments. There are 2 reasons for it. Because they have been trained all their life about what is happening in the brain and spinal cord, upper spinal cord, and majority of the patients or the potential of the possible brain dead donors are admitted under them. Over 95% of the organ donations in our country come from traumatic brain injury. And naturally, they all are admitted under neurosurgeons in most of the centers. So they are the best people to do these assessments, I would say.
Dr. Gupta, I do want to open it up for discussion. So how much, another 5-7 minutes?
5 minutes, I'll wind up. Yes.
No, thank you so much.
Or I can stop and you can open up the discussion now. Let me just finish it quickly.
Yes, yeah.
So basically, you need 1 patient, 2 tests, 4 doctors, 6 hours apart in adults, and 8 hours apart in 12 to 24 hours apart in children. 8 organs, Form 8 and Form 10 have to be filled up. And this is how to remember. The doctor 1 basically certifies the irreversible nature of the brain injury. The doctor 1, 2, 3, they conduct the test together at 6 to 12 hours interval. And doctor 4 is the administrator of the hospital who supervises the administrative aspect to save 8 lives. So this is how you're looking for the motor movement.
Sustained pressure for pain for 10 seconds, minimum.
So you give it 10 seconds
Nothing.
painful stimuli to see for any movement of the extremities.
Okay.
And this is the dorsal movement. You control the endotracheal tube and look for any tonic movement of the eyes to the same or the opposite side.
Nothing. You're holding the endotracheal tube also, so that it does not come out in the neck. Okay. Now in the other side. No. Okay. No cuff.
So this is the cuff reflex being tested.
Dead reflex.
Sometimes you may get some alarm from the sister who may say that child is moving the extremities. Oh my God, the child is still alive. You see some movement happening. Sometimes you get a triple response, and there is no need to worry about it because you may have something called as a Lazarus response. You need to know how to interpret this, and this is a spinal reflex, and it is present in the brain dead patients. In the interest of time, I will skip it. I'll just share my presentation with you. You can read it later on. This is the Form 10, which everybody needs to know and read it line by line again and again, and do not miss out even a single parameter out of it when you're doing the brainstem depth testing in your cases. And where do we get these patients? Most of the patients are picked up from the pediatric intensive care units and the neurotrauma units. The patients can be from the road traffic accidents, stroke, intracranial lesions, and hypoxic ischemic injuries. Let me tell you, a child with a brain tumor, they can also donate organs. So it is not true that if you have a brain tumor, you cannot donate. Yes, you can donate. A child born with an anencephaly, no brain, no skull, they also can donate organs to save others' lives. Child who sustains hypoxic ischemic brain injury, they can also donate organs. Children who have got compound head injuries, some people will say, oh, he could be having meningitis, meningoencephalitis. That is not true. They can also donate organs. Like, for example, this child who had a fall from the walker and he sustained head injury, he was brain dead, but somehow there was a lot of resistance from the clinician. And this child, they inserted EVD and did the EG and whatnot, and child could not be declared, and the child was subsequently declared dead, not brain dead, and the organs could not be donated. So there are a lot of issues when you're doing the certification at times in your setup, which may vary from center to center. So I think in the interest of time, I will skip this, Ms. Pallavi, about this ventilator autocycling. Some issues about the breathing during apnea test, what is to be done. And if you cannot do an apnea test, of course, you need to do ancillary test, as I told you. This is a 7-point CT angiogram. You look for the pericallosal arteries, bilateral MCS, bilateral internal carotid cerebral veins, and great cerebral vein non-visualization. You want me to stop here?
Yes. We do
Okay.
want to open it up for a bit of a discussion and bring in also our coordinators. Thank you so much. There are some questions, Dr. Gupta, but just before we move there, I would like to bring in Angie Scales, who's the lead nurse, pediatric and neonatal donation at NHSBT UK. Thanks for being with us, Angie. And if you could just share your experience in UK and how did it seem different from what we are doing here in India?
Oh, thank you so much for being able to join you from the UK today. Actually, there was a brilliant talk. Thank you so much. It was comforting in some ways to see that we have very similar challenges to you in the UK, particularly around lack of knowledge, awareness, and also confidence in terms of testing. We have had some high-profile cases recently that have ended up in court, which have had an impact on the confidence of clinical colleagues to test. But I completely agree with you, where testing is carried out correctly and you have ensured all the preconditions are in place, then the test is absolutely valid and no one has recovered from that. A couple of points just to kind of pick up on, if that's okay. One, in terms of the lower limit, I was going to ask you whether you had a lower limit, and you alluded to very small children within that. In the UK, we have a slightly different set of tests that we do under 2 months of age down to 37 weeks corrected gestational age, and they only were a guidance put in place from 2015, so relatively recently. And again, reassuring that actually the main difference around those testing is observations of the preconditions, so for a longer period of time in those much smaller infants, so very similar to your suggestions. and also the rise in the PCO2. So it's very more specific in those younger children than it is in the older ones. And just to comment very quickly on one of our biggest challenges is around utilisation of organs, particularly in children under 5 years of age. And it's a real challenge for us and quite a focus at the moment. But that doesn't mean that they're not required and not needed. I mean, we've had a lung transplant. I think our youngest lung donor is 5 weeks of age, with a very successful transplant from that. And just a point on that, our urgent paediatric heart waiting list, half of the patients on that waiting list are less than 2 years of age. That's a real challenge for us. So I'm really interested to hear your talk, and thank you again for allowing me to join.
I just want to ask, is there a hesitation on the part of clinicians to declare brain death in pediatric cases because of the...
Yes. There is. It's something that we're working through at the moment, and it's a real focus for us in terms of training. Obviously, there is some difficulty sometimes in an organ donation organization doing a lot of training on brainstem death testing. So actually, one of the things that has come from the high-profile cases is that our Paediatric Critical Care Society is now much more involved, and our neonatal colleagues are much more involved in leading on this. So hopefully we will see less of that concern around the conflict of interest.
Dr. Gupta, you see the same hesitation on part of our Indian clinicians to declare brain death when it's a pediatric case?
Yes. So that is why most of the people, I would say, they are hesitant to go ahead with the pediatric cases, though it is not so difficult as I enumerated in my talk. And I think we just need to talk about it more and more. There are a lot of potential donors who are missed in my observation.
I agree.
Thank you, Angie.
Thank
There
you.
are questions in the chat, but I would like to at this point bring in Dr. Navdeep Bansal. I also know that he's at this moment coordinating a donation case in PGI Chandigarh, and he also needs to leave. So Navdeep, may I bring you in and ask you to share your experiences about counseling families in case of pediatric donation?
Yes, ma'am. Yes.
Sharing your screen?
Yes, ma'am.
Okay, there is just one question here that somebody asked. Maybe Angie can take that question. What are the additional tests in UK in under 2 months, Angie? If you could, somebody's asked that in the chat before. Navdeep.
Yeah, I was going to put a link, which I will do. I'll put into the chat. Essentially, it's around the preconditions, but also just monitoring that rise in the CO2 in your apnea more specifically. But I'll put the details into the chat and a link to where you can get that guidance and have a look at it, if that's okay.
And Dr. Gupta for India?
No, they are, as I enumerated, the tests are almost exactly the same like in adults. For the PCO2, there is no difference to my understanding in the apnea test interpretation thresholds in children or adults. They're same. You have to document a rise of more than 60 or a rise above 20 than the baseline, even in the children. It's exactly the same.
Navdeep, are you coming on with your presentation? Navdeep,
I think he's doing it.
are you?
Yes, ma'am. But I'm not able to share.
Ganesh, have you stopped screen sharing for Navdeep?
We'll take some additional questions, maybe.
Yeah.
I'll be waiting.
So somebody has said, Dr. Satya wants to know what are the common concerns raised by the family for organ donation in the child. So I think probably Dr. Gupta can bring in the more clinical perspectives, and then our coordinators.
The most common question which is raised by the families is, oh, my patient is having some pulse rate and blood pressure on the monitor. So that means he's alive. That is the first few things. So I always tell them it is like a cadaver with a beating heart. I think we as clinicians, we need to understand the sentiments of the family. And whenever somebody raises this question to me, I always wait. I always say that let the family understand the irreversibility of the condition. So this is the most common thing which is there in the mind. They see that the person is breathing because of the ventilator and the person is having some blood pressure because he's alive. And so they do not accept it. This is my observation over last many, many years.
Over to you, Navdeep.
Good evening, everyone.
evening.
So the medical aspects and all regarding the brain death in pediatric.
Can you make a full screen, Navdeep?
Slideshow.
Is it possible?
Niche slideshow kar do.
Is it okay now, sir?
It's
Navdeep,
okay,
just
carry
go
on, don't
down
worry.
and there's a slideshow sound right on the lowest bar. And next to that,
Right. Go right. No.
Right. And the
Yes.
next one, yeah, Navdeep.
Yeah.
Good to go. Yeah.
So now we are going to discuss regarding experience in pediatric donation as a transplant coordinator. So in PGI from 2015, we have converted nearly about 30 patients which were below 14 years of age. As discussed by Dr. Deepak, that it requires a extra efforts to declare these children for brain death declaration. So we always try to involve the treating physicians and the pediatric neurologist when we are going to declare these kids regarding for the brain death declaration. So what are the challenges as discussed by Dr. Deepak also, that reporting of cases is very rare. Most of the medical fraternity, even the medical fraternity is not ready to inform these cases who can be the brain dead or can be the potential donors. So reporting of these cases is very rare. We got approximately 1 or 2 kids in 3-4 months, which can be the potential donor or the potential brain dead patients. Then and also the second challenge is that whenever we try to counsel these patients, the parents feel guilty. As the cause of brain death can be in the most of cases which we converted by the fall. It may be fall from height or fall from the bed or from the lap of the parent. So they feel guilty. So it's very difficult to make them convinced that it's not their guilty, and they refuse that this thing happen due to our fault, and we are not going to further disfigure our child, or we are not going to give any consent for organ donation. So this the guilt feeling in the parents is also a great challenge to overcome while counseling these patients. And also, if they the reason of the brain death is due to any disease condition or the other factors, they also feel guilty in that also. And difficult to explain use of organs. Sometimes they are ready to give consent, but they will ask that where you are going to use these organs. It may be, and always we may not have the recipient in the same age group, or a kid who require the organs. We may have to put these organs in an adult patient also. So they, it's very difficult for them to understand that their organ of their baby or a kid is going to be utilized for an adult patient. So it's again become a challenge when we are going to do the counseling to these parents. And body disfigurement, it's also a great hurdle while we are going to ask them for organ donation, as most of the cases will be non-MLC. Even if it's MLC case, if it's a MLC case and no, then also no third party is involved. It will be most of the cases it will cause of MLC will be the fall from height or anything where the third party is not involved. We can justify this body disfigurement in case of adults, as they have to undergo the legal procedures. They have to take the claims from the third party, or they have to take the insurance. But in case of children, no other person is involved, and whenever we explain that child is no more, he or she can be a brain dead, then they will opt for LAMA. They will not go for the medico-legal procedure or for the postmortem. So the body disfigurement is also a great challenge to overcome when we are going to counsel these parents. And also when we are counseling, then it may be only a single child of the family, or the for that particular couple, that They will not listen anything when you are going to approach parents, and on as a coordinator, your own emotions when you are going to console the small kids may be a factor when you are going to console them, which may not be there when you are going to console adult patients. So these are the some challenges which we face as a coordinator when we are going to console these parents. And there, when you are going to address the various family aspects, there the family have various aspects when you are counseling them. And if they get agreed for the organ donation, then they may have some particular demands or something that you may fulfill. If you can fulfill, like when we were counseling a family, they were asking that our kids should be in our when you will give the body, that our kid should be in his own clothes. There should not be any mortuary sheets on the body of that kid. And even some of the family ask for the particular toy to be handed over to the family to that kid when we are going to hand over the body of that kid. And one of the family demand for it's a doctor family. The kid was I think 12 years old, and that's where the family was from a medical background. Since we did the demand for an extra brain dead declaration committee for that kid. So we go for the third brain dead declaration committee, although it was not documented, but for the satisfaction of the family, we go for the third brain dead declaration committee for the satisfaction of the parents. And ultimately, after that third brain dead declaration committee, they give consent for organ donation. And even in case of small kids, there is the involvement of the grandparents. Like in case of adults, it's usually the spouse or the parents of that patient that for whom we have to convince for the organ donation. But in case of kids, the grandparents also play a major role while we are going to counsel them. The parents may get agreed, they may be in the hospital or they may be there to give the consent, but they will always go for consultation with their parents. So all grandparents are usually mostly more attached with their children. So convincing them is also a difficult task to take consent for organ donation. And less utilization of organs. As my experience, the most of the families are willing to donate only the heart and the eyes of their kids. So because they want to listen as the media advertisement, all they want to listen the heartbeat of their kid, or they want to see the eyes of their children. So they were not ready to give consent for the other organs. So and it's very difficult to use heart and eyes currently in our country from these kids. So now this was just a case discussion regarding as also mentioned by Dr. Deepak in his presentation, that it was a kid of nearly 70 hours, and I think it's the youngest donor in our country. When I got a call from the pediatric emergency, and I visited that emergency, then I checked all the details of that patient, and I see that it's only 70 hours old neonate. So we were not ready, or we were not sure whether we can go for the organ donation from such a less age neonate or the kid. Then I called all the transplant teams whether we can retrieve the organs or not. Then we searched a lot of literature, and some literature was there that yes, we can go for the organ donation. Then I counseled this family. It took I think more 1 or 2 hours to convince them. The kid was with some congenital malformations, no brain development was not there, and they gave consent for DNR. They have already given consent for the DNR of this kid. Then I counsel them for organ donation, and and it was a DCD case. So after that, when they give the consent, we wait for the cardiac arrest, and after that, this patient was shifted to the OT, and the kidneys were retrieved from this kid. So I think it's the youngest kid in our country who become as organ donor. And second case was of Ibadat. It was a young girl of 39 days only. In this case, the parents were self-willing. They approached us that yes, that they want to donate the organs. They were aware about the organ donation from various sources, and they approached us that we want to donate the organs of our daughter. Even this case was discussed by the Honorable Prime Minister in his 99th Mann Ki Baat. So it can be a good example for all the other coordinators and all of us who are working in this field to motivate other parents to go for organ donation. So this is the success story. Recently, PGI celebrated in the last month only celebrated 50 years of kidney transplant, and these two recipients were called in this event. And this woman is having a dual kidney transplant from a 11-month-old kid. So this woman got kidneys, dual kidneys from a 11-month-old kid, and she's doing well. And she was transplanted 5 years back. Now she's very well, and she's having own business of river rafting in Rishikesh. She's enjoying her life. And second one is a child having a kidney transplant from a 3-year-old kid, also 4 years back, and he was also invited in this event. So it's a success story that the organs from such a young age can also be taken. And if families are motivated, parents are fully convinced, then it can be a great factor to increase the shortage of organs. So this is the success story that these organs are valuable. Thank you.
Thank you so much, Navdeep. Thank you for the good work you do. I'm sure it can't be easy speaking to families in the case of such young children. I just want to get a clarification. Did you say that in medical legal cases, the children are never made to go through autopsy? Is that right?
Usually, family don't get agreed for the autopsy, as no third party is not involved. They don't have to take any claims from anyone, so they opt for the lama before even declaration of death.
Dr. Gupta, could you talk about what is the situation in medical legal cases in children? Navdeep, you could just stop sharing so that we have.
Yes, ma'am.
If you could just stop sharing your presentation so we can see Dr. Gupta. Thank you. Dr. Gupta, you're mute. You're on mute, Dr. Gupta. Ganesh, have we made it? No, I'm open. I'm speaking. So what's happened?
Okay, now it's okay.
Yes.
Okay, so I think the law is very clear in our country. All road traffic accidents, they are medical legal cases where autopsy is indicated and should be done. However, there are some exceptions in some states wherein you need to take special permission from the higher authorities, from the police, wherein exemption can be given if the cause of injury is well known. Having said that, what we do at All India Institute of Medical Sciences nowadays since last 1 year is to take this important fear of autopsy. What we do is during the time of organ retrieval, we ask the forensic medicine person to be physically present during the retrieval so that he or she can inspect the whole of chest and the abdomen for any injuries or anything sampling. And after the retrieval, when the body is closed respectfully by the surgeon, then we ship the child or the adult for a whole body CT scan. And it's called vitropsy. And this obviates the need for the second opening of I use the word second postmortem. This obviates that need. And also, I have used this during my counseling, and many of the families, they have shown positive response. It cuts down the time significantly while waiting for body to be sent. In some cases, the body has to be sent to another hospital, civil hospital, for the autopsy to be conducted, for the forensic medicine person to come. And then, as a rule in our country, majority of the people, they would like the body to be taken for cremation in the adults before sunset. So all these things, they need to be respected. Children, of course, very young children, they are buried in our country. We all know that. So, but I think this autopsy issue is a very, very sensitive issue, and we need to follow the hospital and the state guidelines. And in our center, we do this, what I've just told you.
Because I agree with you, Dr. Gupta. So I'm wondering how, what Navdeep was saying. So in cases, Navdeep, where the organ donation did take place, in medical legal cases in children, the
Yes, ma'am.
autopsy would have been done, right?
No, ma'am. The same we are following in PGI. Even in case of adults also, we have given we give instruction to the retrieval team that the notes should be appropriate, which the fancy team needs. They will put all the proper notes regarding the organ they are going to retrieve. So most of the time, they don't open again they don't open body again. They give findings according to the retrieval notes.
The problem comes regarding the head. In case person has not undergone
Head opening. In case of FIR, the FIR is registered. But in case of if there is fall or if the person skid from the vehicle, in that case they don't open body again.
Yeah, because the opening of the head is very brutal, I would say. You know, those who have seen autopsy being done, they use those saw and everything. The necrotic brain is pouring out. I've seen it being done in the operation theater also to save time. It's a total mess, and just not an effect. It just and that is why we started doing vitropsy, and it is really a game changer for our center and saving a lot of time. And it's fine because this is what we were doing during the COVID pandemic. And I think one issue which we have not discussed, I had just 4 slides left. If I get permission, I could share those just last 4 slides. May I?
Sure.
Coming from Dr. Gupta, talking about, opening of skull is really something, being a neurosurgeon.
My goodness, Dr. Sharoff is there. Sir, good evening. Is my screen visible? No.
Now it's come. Yeah, you just need to put it on slideshow.
Do we have some time to discuss some of the challenges which we face in pediatric donors? I mean, I know you had some. I joined a little late.
I will discuss just 4 slides. I promise, just 4 slides.
Sure.
Regarding consent from the family. This is if you look at the law very carefully, it says anybody who's less than 18 years of age, any of the parents of the deceased person may give authority for retrieval. But I think it's preferable, but not mandatory to have consent from both the parents. I open it to discussion. At least in our center, we take consent from both the parents, especially more so in the children. And if the parents have expired, naturally the grandparents or the siblings can consent. So I think you need to take consent from both the parents in pediatric cases. Dr. Sharoff or Navdeep, do you have a different opinion on this, or what is the take?
I think it's very safe to do that because many times we have also seen that there have been some indifference in the family between wife and husband. And, one of them had given consent, the other person is not present. And when we ask, they say that, we have some problems in our relationship. So that becomes a little tricky. In one case, we had the father giving and the mother was not there. We were not comfortable at all. So between the father and the mother, if you ask me, I would definitely want the mother to give the consent. If the father is not there, then I would probably not insist too much. But definitely the mother should be there, is my personal opinion. Of course, if you have any other opinion, I'll welcome.
Navdeep, do you agree?
Yes, sir. We also go with the consent of the one parent also.
One parent.
But most of the time it will be the father who used to be remain in the hospital or with the kid. So I
think it's more of a center specific and a state. The law is very clear, at least one parent. But I think it's always, you need to follow your center policy. At my center, people like to take consent from both.
I don't know about the center policy or the law, but I think it's only ethical that both the parents are allowed to give consent.
Both the parents, yeah. Then consent for apnea test. Actually speaking, you don't need any consent for the apnea test. Many times I've been asked whether you need consent from the apnea test. You don't need, because it is a test. It is a test which is being done for brain death certification in a person who is having an irreversible injury. And there is a lot of fear in the mind of people saying that apnea test can actually kill a person, which is actually not true. This is only the fear in the mind of the testing person, because most of the times, if any instability happens, it happens within first 10 seconds of the disconnection, and you can very easily reconnect. By and large, if we have done the preparation for the apnea test correctly, the patient blood pressure on the higher side, you have primed the patient, given 100% oxygen for 10 minutes, you are very safe in the apnea test, so you don't need a consent. Am I correct, Dr. Shroff? Or
Yeah, absolutely. And the law itself says there's no need of consent.
Okay.
Angie, you're talking about the apnea test or the consent for donation?
Sorry, was that a question to me?
Yeah.
It was,
Yeah.
and so no, that is consent for donation.
Yeah. Even I got confused. There is no consent needed for the apnea test, but consent
No, not at all.
has to be ideally and ethically from both the parents.
Nowhere in the world, consent for apnea is required.
Not required, yeah.
By the way.
Yeah.
Not required. Okay.
Because
So to summarize-
apnea is a clinical test in a way, an extension of a clinical test, which is validated by doing ABG, the blood gas analysis. It is only part of that to confirm brain death, diagnosis. So nowhere in the world apnea test requires a consent. That consent has come for apnea test from private hospitals in India. They are confused about it. Is all I'll say.
Yeah. So the carry home is like it's a clinical diagnosis in our country, but one needs to be cautious in applying brain death criteria in the young infants. Observation time of the two apnea tests in children is different from the adults. And again, I want to emphasize that you need to document and sign each and every document timely, because you never know when the case can be reopened many years down the line. Acceptance rates by the parents may be lower, but my personal observation is conversion rates is very high in pediatric brain death certifications. And I think I stick to my word that knowledge gaps amongst treating clinicians and surgeons, they need to be addressed. And I think this webinar is one such attempt to address those knowledge gaps. I, as a neurosurgeon, I think I'm convinced, because I feel that it takes many people to make a donation happen, and everything has to fall in place for a successful retrieval and transplantation. All we need is a change in the thought process from it being a thankless job to a passion to do is needed. I believe if not we, then who else will do it? I think with this, I just want to put up the picture of the children. We have done 5 cases in last 1 year, Mansi, Rishant, Mahira, Roli, and this year we had a Salim, a 6-year-old child. The youngest being just 16 months of age in our center. And we are looking for each and every potential or a possible brain dead pediatric donor for conversion. With this, I would end my discussion, open to any questions from the attendees. Thank you so much.
Thank you, Dr. Gupta. We need more passionate doctors like you. There's a question here that says, what do you advise if the second apnea test is inconclusive? Example, the CO2 did not rise sufficiently. And what is the gap for the next attempt of the second apnea test?
So the second apnea test has to be done minimum of 12 hours apart in the pediatric population, sometimes even longer. The majority of the cases, second apnea or the first apnea being inconclusive is because of you do not read the pre-apnea or the baseline ABG test correctly. I've seen people doing the ABG, and on the ABG, arterial blood gas, if the PCO2 value is 35, as per the rule, of course, you can do it. But believe me, it takes longer time. If you begin your apnea test with a PCO2 value of 40 to 45, that means on a higher PCO2 value, your chances of hitting are very, very strong. So begin with a high PCO2 value. Play around with I never ever begin my apnea test with lack of priming of the patient. Sometimes I do some kind of a cheating, I would say, in the sense the patient blood pressure is borderline. What I do is I give a small baby bolus or a purge of inotropic agent, NORAD, to the patient to keep the BPO slightly on the higher side. Because I know that when I disconnect the child or the adult from the ventilator, there will be metabolic acidosis, the blood pressure will definitely fall. I do not want the blood pressure to crash below 90 millimeter of mercury or saturation to fall further. So pre-oxygenate a patient by 100% oxygen for at least for 10 minutes, maybe longer. Your oxygen catheter has to be correctly placed. So many times people do not know where to place the oxygen catheter. It has to be 1 centimeter distal to the endotracheal tube to be just at the crina so that you're able to ventilate both the lungs. The problem with the apnea test comes, or the inconclusiveness comes only when you do it incorrectly. Having said that, if you do not have a rise of PCO2 to more than 60 or more than 20 than the baseline, you can very safely extend the duration to 15 minutes, 1-5. In fact, up to 20 minutes also, provided the patient is stable, not showing any arrhythmias, the metabolic acidosis is not happening, the respiratory acidosis is not happening. And even despite that, if you are not getting it, just reconnect the patient to the ventilator and do the test again within next 24 hours. It could be 3 hours apart, it could be 6 hours apart, but it has to be done within next 24 hours. You have to remember, a person when he or she is brain dead, the organs are failing and you are pushing in more and more efforts. The suitability of the organs, they deteriorate with each and every passing hour. So the key to successful or a good attempt to brain death certification is to give healthy organs to the retrieving team. So your sodium has to be kept to less than 160. The only reason being hypernatremia is very bad for the recipient liver. Similarly, lungs have to be taken care of. You're not supposed to push in too many inotropes because then the kidneys will be affected.
The person who asked that question is said they're satisfied with the answer, so that's fine. If it is a premature birth at 7 to 8 months, and is it possible to go for organ donation?
No, I think it's about 37 weeks of period of gestation. See, you have to understand what I was emphasizing. You have to understand what are the organs you are going to harvest. On a theoretical front, it may look very exciting that a preterm baby, let's say 28 weeks, you are attempting organ donation. But if you look at the practicality, there are hardly any such cases. So many times we come across pregnant patients, a 20 weeks, 24-week pregnant lady who sustains severe traumatic brain injury, and she's having a live fetus. And this question probably comes to relevance at that time also. What to do with the baby. So baby has to reach an age of maturity, that is beyond 28 weeks period of gestation. But regarding premature or preterm, I don't advocate. I would still advocate that any child who is older than 37 weeks period of gestation, you should think about it and talk about it. Dr. Shroff may add to it.
Yeah, I think, only if the family is very keen to donate, and I think the only way forward here would be a DCD donation. Brain death, definitely not, because, the neural tracts have not matured, so you can't really define those, your clinical tests. So DCD is the only perhaps option. I don't know what the international experience on this is, but yes, I don't think so. And also we must remember whether these organs can be used, perhaps they would possibly could be only used in pediatric recipients who are also of a certain age because of the size mismatch and so on. So there are a lot of challenges in this.
Anna wants to ask a question. Anna, please go ahead and unmute yourself.
Hello. Hello, this is Anna Mazzeo. I'm from Italy, and congratulations to everyone for beautiful talks. I would like to ask this question because probably the regulations, the laws are different in different countries. I heard that you were talking of consent to apnea test. So apnea test is part of a clinical diagnosis. At least in our country, we do not need consent to do the clinical diagnosis of brain death. So I was wondering why you need the consent to apnea test.
So, Dr. Anna, as I said, a consent is not needed for apnea test. Some people, they do ask whether you need consent for the apnea test. Let's say when you want to do any invasive procedure, tracheostomy, or any procedure, you always ask for consent from the family. And so many clinicians, out of ignorance, I would say, they say you need consent from the apnea test because they have a fear that this patient may worsen during the apnea test. Probably that is why they ask, but the thing is very clear. You, as you rightly said, you do not need any consent for apnea test.
Thank you.
Thank you. Thank you.
Munir, go ahead, ask your question.
Dr. Gupta, what I know a little bit about the law, it's not very clear about the ancillary testing. So I'm again asking this question that where the certification is not possible in children, and you have mentioned that you can go ahead with ancillary testing and your center is doing it. So is it we can do that in other centers? Is that what law says?
Yes. Yes. So there was a beautiful paper which was published in JAMA 2 years back, 2020, I suppose. It's a paper, it's a global paper. I think 2 countries are currently doing ancillary tests, and the NOTO also permits, there are some children wherein you cannot do various clinical tests, as I pointed out. Some children, you will not be able to do an apnea test properly or correctly. In those cases, you can do. And at our center, we have started doing a CT angiogram. CT angiogram is a very simple investigation. You just have to, through a central line, you have to inject the contrast and take the delayed films of 20 seconds and 60 seconds. And on 60-second film, the 7 vessels which I talked about, 3 veins and 4 arteries, if they are not visualized, the intracranial component are not visualized, that means the cerebral blood flow is absent. See, all we have to understand, we all die, let it be a cardiac death or a brain death. They all happen due to lack of cerebral blood flow. If a person dies by the cardiac death, naturally the blood flow to the brain does not go up. So there is a lack of cerebral blood flow to the brain even in a cardiac death. When a person becomes brain dead, again the cerebral blood flow to the brain stops. And this is what we have to document. So when you demonstrate on CT angiogram or a digital subtraction angiogram or IADSA, lack of cerebral blood flow in the intracranial circulation, it is an indirect evidence that this person is brain dead. It is an ancillary test, and this can very safely be done in cases where the clinician is not very sure about the interpretation of certain tests. Let us say in one case, actually at my center, I remember very distinctly, last year, the case I showed you about the Lazarus sign in this child, the entire ICU, even my neurointensive, my intensive colleague who was a very senior professor, that person was also very doubtful that this child is probably having some motor movements. And I, as a clinician, was very sure of what I was doing. But to allay the anxiety of the entire ICU and the entire team, and to build up the trust on the program, I decided to do a CT angiogram in the child. And yes, of course, the CT angiogram was 7-point CT angiogram was positive. That means the brain death was confirmed, and this was shown to the entire staff, and they all believed in the concept of something called as a Lazarus sign. Similarly, in one case, we could not get an arterial access despite the best of the try because of multiple things. And then in that case, we took permission. We did the CT angiogram as an ancillary test, and subsequently, this child did donate organs to and saved, I think, three children. Yes, it can be done.
I 1 minute, Palvi. I agree with you, Dr. Deepak, and I also understand the test, what you're talking about. But my point is, 3 years back when I was in hospitals and doing counseling, the clinicians, they want it in writing, that where is it written in the law? You're talking about permission from the NOTO, which means that for every case, you need a permission from the NOTO, because NOTO as such has not given any written guideline. So the clinicians, they say, where is it written? Show in the law. That is what, I mean, I would agree with you that clinicians also need to be, what you've said in the last point, that they also need to be educated. That's my point.
Dr. Shroff, would you like to answer this?
You have to unmute yourself.
You are muted.
Sorry. I mean, Muneet, you're talking about DCD, is that right?
No, I'm talking about BSD.
Apnea test.
I'm talking about apnea test.
What do you mean? Sorry, I had missed a little bit when I'm taking a call. What was the question? What was the doubting about?
Question is where the apnea, you cannot do apnea for some reason in children.
Right.
Yeah, and then comes in the role of ancillary, which is not
right.
there.
You're absolutely right. Law doesn't, that definitely, you're right, that the law wants apnea test as a test. Without that, you can't declare brain death. Period. That needs to change.
Yes, that's what I was saying, because every time you need to get a permission from NOTO, AIMS is doing it, other hospitals don't do it. The clinicians, they want it in writing. Where is it written in the law? Show us.
Very true.
But Muneet, like a Dr. Gupta calling up NOTO and saying, we want to go ahead with this case, and not leave it to a transplant coordinator to do the asking. If that conviction and passion comes across from doctors, it will happen because
Yeah, it will happen.
it is beginning to happen now.
I agree. So motivated, passionate doctors like Dr. Gupta, very few in this country.
Okay,
So
let's
इसलिए
move
नहीं होगा
forward.
सर. So there's a, before people start leaving, we have a very small poll. Ganesh,
By the way, before that, I just want this question to be answered of miracle, since Lazarus
yes,
side is
we
being
will
talked
come to
about.
that. But people are logging off. Dr. Shah will just do the poll and then we can have this question.
Fine.
So Ganesh, if you could just do that, so that whoever has to leave can leave, and then
So we want to know whether you handled pediatric donations or not in the group. So just click on the poll and submit, and you'll get the answer.
Where do we click it?
You click on yes or no.
no, it's not getting clicked.
I click. No, it's not clicking.
I have finished my vote immediately.
मेरा भी नहीं click हो रहा है, Dr. Shah.
कौन से पे हो आप लोग, कौन सा सिस्टम यूज कर रहे हो?
Lenovo.
I finished, ma'am. I have submitted.
Okay.
We'll add 2 more to the yes or no. If you can say you said yes or no to the file.
Mine is a no. Dr. Shah, Dr. Gupta is a yes.
Of course.
Yes, from my side.
The
Dr.
help-
Lakshmi.
While we're doing that, you can answer the question, of miracles.
So yeah, so there, Prakash Lobo wants to know what is the role of miracles. Yes, we do.
Very, very
confirm-
important in our country, miracles. So please.
Yes,
use
we do
the-
confirm in brain death certification, but I've encountered a person asking me the above questions. So will you give time for families to look at the possibility of a miracle?
You're asking me?
Yes, Dr. Gupta.
Of course. See, this is, as I told you, this is such a sensitive program. You should never ever force something on the family. All you can do is to keep the organs healthy and functioning, and try to understand the irreversibility of the condition. In fact, at my center, I never ever open up the discussion for organ donation till the time family has understood and accepted one very basic fact. This is an irreversible condition and the person is not going to come back. Till the time they're expecting miracles, please do not talk about organ donation.
So here the question is that, for after brain death certification, can there be a miracle, in a child, for a child to come back to life? Because, with this Lazarus sign and so on, which sometimes does happen, that can kind of give some false hopes, both sometimes, as you did in your case, to a clinician and also, of course, to the families.
It just shows that the family has not accepted death. And that is obviously, like Angie has written, is not a right time to ask for organs, because
Yeah.
it's just
And,
another way, another defense mechanism to not accept death.
In fact, it is also advisable, especially in patients who are on long-term ventilatory support, the children, if we have encountered a Lazarus sign in the ICU and the brain death is certified, confirmed, family has agreed for organ donation, many people have recommended to give muscle relaxant to the child before shifting the child to the operation theater or on the table. Sometimes it so happens that you are giving an abdominal incision and the person may make a Lazarus sign and may make a partial attempt to get up, but that's a spinal reflex. So it's always sensible, once you're very sure about the brain death certification being done, irreversible mode of injury being shown on the CT scan, apnea positive, don't hesitate to give a muscle relaxant before shifting the patient to the operation theater.
Some clinicians, some intensivists want, the family to be there when they're doing the brain death certification, like Rahul Pandit. So if you're going to do that in your practice, always warn the families that there may be some movement when you're doing certain tests. And that does not mean that the person's brain is functioning. That is very important to, tell the relatives that certain small movements may be there. If you don't tell them and you see Lazarus sign and the family is watching, it's all over.
And I think, sir, we should not be scared about the Lazarus sign because there are some special tips. I skipped it in the interest of time. I'll share my
I
presentation
know,
with everybody.
Dr. Deepak, I'm saying that if the family is there watching you doing brain death testing, at
Sir.
that time something like this appears and you haven't told the family, then it's all over.
Yes, sir.
Okay, very quickly, I want to open it up to the audience. If anybody wants to share their experience of counseling a family where there was a pediatric donation, if there is anybody who wants to do that sharing. And my second question is going back to Angie. Mohan Foundation has a formal MOU with NHSBT UK for information sharing and knowledge sharing. Are there any specific training programs that have been designed for counselors to do pediatric counseling that we could learn from? Angie? Anybody wanting to share? And Angie, are you still there?
Yes, I am. Sorry, I couldn't take myself off mute for some reason. We don't run any specific courses for counsellors as such, but it's something that I could perhaps find out. That's we as in NHS Blood and Transplant. I can find out if that's helpful.
Perhaps something we can put together.
Yes. Yeah, absolutely. Thank you.
I think
Anybody here? Sorry.
what will help, Pallavi, is I think, if you can come up with some case discussions of specific scenarios where they had difficulty in counseling and how they handle, especially people like Bhanu, who are very senior coordinators, people like from, PGI, and of course, Dr. Deepa Gupta. So if they can have certain case presented, maybe we can do another session on pediatric donations and just go for, rather than just, talking about the clinical side. If we talk only the counseling side, it will be of great help to everyone.
Okay, so Dr. Lakshmi wants to speak and she's saying she's unable to unmute herself. So Ganesh, if you could help with that.
Bhanu, you want to say anything also? Bhanu has got a lot of experience. Lalita has a lot of experience as well.
Yeah.
Hi, this is Dr. Lakshmi Shubhavat. I am a pediatric intensivist from Wadia Children's Hospital, Mumbai. And recently we had our first pediatric brainstem death and organ donation, which went through. All the questions I asked were based on that particular scenario, and it was not an easy scenario for us because we had neurosurgeons saying on 160 sodium, I'm not ready to do the apnea testing. Then we had to find papers where it is an extended spectrum and it is allowed to do on 160. Is there a comment from the forum on 160 serum sodium for doing apnea testing when clinically everything else is fitting?
Getting the sodium down from 160 to 159 may not have been that difficult, but I understand, Dr. Lakshmi, your kind of problems when you're doing the first time an apnea test after the consent has gone through for something very small, just a requirement, you're not able to go forward. I do understand, but sometimes these parameters have to be defined and you have to define it somewhere. So the difference between 159 and 160 is not likely to be too much, but unfortunately these kind of criteria have been defined on the national guidelines. And we have kept 160 as the marker for sodium. But if you give, if you had an NG tube and if you give some water and so on, and if you get given dextrose, I think bringing from 160 to 158 or 1 may not have been so much of a challenge. Is my personal opinion. Dr. Gupta, you can maybe elaborate.
Yeah. So see, as a neurosurgeon, I would say that the confounder factor to the apnea test interpretation will actually be a low sodium, that is less than 115. So if we have a patient who is having a sodium less than 115, then my chances of committing error in the diagnosis are very high. This 160 is bad for the liver, for the donor, not for the apnea test. Having said that, I think there has to be some limit needs to be set up. Some people have gone to 165 also. But majority of the papers which are available in the international literature, they're talking about 160. In my center, people were fighting initially for 150, then 155. Now they've agreed for 160. So I have made a SOP for my center. And now it's been a year now. Now nobody argues. Once you start delivering the result to your center, then people will not question you. Number one. Number two, as Dr. Ashok rightly pointed out, in your first initial 1 or 2 cases, you may be so pumped up to say, like this child needs to be certified ASAP. That usually does not happen. You need to have patience in certification. because certification is not everything. You know, a lot of things happen subsequently also. And what we do is at our center is 50% of the fluid we give it via NG tube, and 50% of the fluid we give it via the 5% dextrose with some neutralizing 6 to 8 units of insulin. And it usually works well. And sometimes in fact, we also add those prokinetic agent, IV metoclopramide or ondansetron to the patients to increase the absorption of the water. It works well, and maybe it may take you another 2 hours, 4 hours, but I think it works well. 160 is fine. You can quote Ames and me, no problems. And there are many papers from UK.
Yeah, my neurosurgeon was not over with an oral recommendation. I was continuously talking to either Rahul Pandit or Dr. Sunodani because there were so many obstacles which were just like, phone mein nahi chalega. Dr. Lakshmi, aap paper dikhaiye. So then I was really stuck on many things, but eventually it was a late. I would like them, please.
I have the papers.
I did have a 150 sodium when I did the first apnea because the 160 was a little older report and we were already giving free water.
Lakshmi,
So
you have to understand,
that-
Dr. Lakshmi, you have to make people understand one very basic fact. When a person is brain dead, each and every person will have hypotension, each and every person will be hypothermic, each and every person will be hypernatremic because of DI. Even for temperature, people argue, what is the temperature you should take? Some people say 96, some 97. At my center, I take it 95.
35 degrees.
So, in fact, to raise the temperature, 95 degrees Fahrenheit. So I take the temperature as a cutoff because the thing is, when you are doing the second apnea test, you've got enough window. 6-hour window is there, wherein the temperature is likely to rise up. And there are some papers available for 95. I think UK takes 95. We take it 95 as the initial test.
Yeah, so second time around, that is what happened. Like, even when we kept the baby open, the baby's temperature would fall and everybody would look at the inside the sheet and trying to see. So it was really tough in the second apnea. We had a bad time. I agree with point where I thought probably we did it at 45 and therefore we didn't reach that 60. We were stuck at 58 for a long time. Then we finally had to resort to the
It's great
ancillary
that you made it
tests.
happen, Dr. Lakshmi. And
I do hope, Dr. Lakshmi, that this is a step forward and you keep doing it. It doesn't dissuade you from doing any more because you have such an opportunity, and I know in Paediatric Hospital to do
Very heartening to go through, and yeah, it was very good experience. Though it's sad for the family, but it was a very good experience for them.
And thank you for joining this webinar also.
it just shows your commitment to the process in the future. Ganesh, could you please unmute Lalita ma'am? I think you could unmute people, whoever wants to speak.
Yeah, just unmute everyone.
It's the last couple of minutes. Just let everybody be unmute if they want to be.
Yeah. Unmute.
Actually, all of them have that.
But Lalita is not able to unmute herself, Ganesh. Yeah.
And Bhanu, if you can.
Yeah.
Bhanu is not here, Dr. Shrav, but I just want to say that you had put in the comment that, sometimes the parents themselves come forward to make a donation. Way back in 2005, we did a 18-month-old boy. The father was a major. So they themselves came forward to make a donation. So it was a very, very easy donation. And following that, we had an 11-year-old boy who was declared brain dead after an accident. Again, the parents came forward to donate organs. I also want to share on behalf of Bhanu, who did a pediatric donation just 10 days ago. This was a 12-year-old boy, a laborer's son. And I believe he was pestering his parents for the past 6 months to buy a mobile phone. And they couldn't afford it. And the father yelled at him that he has to go to school and that he's not going to buy a mobile phone. Unfortunately, this boy committed suicide by hanging.
My God.
Saw on YouTube, I believe, as to how to hang, and then he hung himself. Very sad. And then the father agreed to donation. The mother didn't agree to donation. For 24 hours, we waited. And then we got the mother's donation also, and the donation went through. So, some of you were saying that consent of one parent is enough, but somehow we believe that we need both the parents' consent, and especially the mother's donation is in children's case. So we waited, and in some cases we have gone to the homes of this potential donor and convinced the other parent also. So I feel better to get a consent from both the parents.
I agree with you. Yeah.
Thank you, Lalita, for sharing this, because when we started this program, we didn't even have the heart to ask pediatric donor parents. And we as clinicians used to hesitate even to approach them. And in many instances, when donations happened, it was the parents who came forward spontaneously and said, "We want to donate." And that's why
I believe it could still be the case for many of our counselors and our doctors not to even initiate a conversation, if it's a pediatric donor.
Dr. Deepak Gupta is our hero, so please share your email.
Everybody wants your number and anybody else? Brinda, you have any experience? We'll just last 2-3 minutes before we wind up. Anybody here wants to share? All right, our other speaker.
As all were saying, in our hospital also, we believe in taking consent of both the parents, especially when it is a pediatric age group case, because it's always better.
Yeah,
definitely. Our other speaker, Shiva Kumar, was called off. They are having an NABH.
I also wanted to ask some of you, between the mother and father, who do you think should be the one who you should really, if there is mother, available, father available, and mother is not available, would you like to get the consent from mother or not? At least I feel in Indian situation, the mother should be consulted.
Definitely.
The long-term pain for the mother is much more perhaps than the father. I don't know. I'm just being,
I agree.
And that's a politically incorrect statement to make, Dr. Shroff.
I'm not question of incorrect. But I'm just saying, I have whatever experience I have had from that.
No, definitely for the mother, it remains for life. So I think giving that much importance to mother, her feelings, I think is vital.
Yeah, Anna.
Anna wants to say something. You
have to unmute yourself.
You're mute.
Please.
Somebody needs to unmute her.
Ganesh, please unmute everybody. Yeah. Go ahead, Anna.
Okay. Sorry. No, I was listening to the consent of parents. At least in our country, it's mandatory to have the consent from both parents, of course.
Yeah.
I don't know if because I was working, so I may have missed some part, but you were asking if also the mother has to sign or who is that has to sign. And for example, just 2 weeks ago, we had big surgery in a patient. We had to wait also for the father to come because he was not there before the surgery, because both parents in our country has to sign. The same is for organ donation. At least in our experience in our country. Thank you.
Thank you. Dr. Parul, and let that be the last question of the evening.
Good evening. I'm Parul, transplant coordinator, PGI Chandigarh. We have counseled many pediatric cases in our institute. The consent that we had was from 48.5-year-old neonate. The parents were willing for organ donation. But in the discussion where we are talking we need the consent from both the parents. But in our scenario, normally the mother is not present in the hospital. We have just the father and the other relatives who are present in the hospital who are not even willing to discuss the condition of the patient with the mother or other relatives, those who are not present in the hospital. So it becomes... Yes, sir.
We're not saying that, we are saying it is preferable to do that. If you have one, signature, that's fine. But we personally feel it is good if both the parents are involved in the consent process, so that afterwards there's no rift in the family, between the family, because we want everything to be, good for the family. Good. They shouldn't, he shouldn't go back, and the mother should not get upset, and so on. So it is preferable to have both the parents consent. But if you have one parent who is signed and you're not able to contact the other parent is okay. I mean, we're not saying that you have to, but it's a good practice to do that. That's all we're saying.
Like Prakash has shared in the chat that, the
Good
mother
practice.
was willing to donate, but she was so scared what the, husband would say if he got to know. I think these cases, if both the parents are alive, both their consent have. It also to ensure that, they are collective in that decision making, they feel good. The marriage doesn't suffer going forward. So it's
a good
only right
practice.
that you get consent from.
Right.
Yeah, actually, we do not know, Pallavi, what may happen a few years down the line between
Yeah,
the
you
two
took this
parents.
decision
So
without
many
asking.
times the father comes and tells me, please take the organs, I'm ready to sign. And the mother is away, she will not even come to know about it. We'll go ahead with the burial of the cremation, but we say no.
I mean, if you kind of, wait, pause, and, then, give them some more time, invariably you'll find that, things will come out well, things will work out well for they will consent, they will speak to the.
One father, in fact, told me that I will get it signed by her and I will tell her subsequently. Right now, I cannot tell her. And I said, there is no way I can go ahead with this unless I have explicit consent from both the parents. It is a right to be told and.
So just go back with this, that it is a good practice. It is not, in the law only requires one signature. So it's a good practice to do that. And you can do it however you want in your program. But, at the end of the day, you want to keep this program, going well without any controversies. So try and follow these good practices is all we say.
True. So should we wind this up? Dr. Gupta, thank you so much for always taking the time and, sharing your experience with such heart. Navdeep Bansal, I think, has gone to coordinate the case that's happening. Unfortunately, Shishir was called off. But thank you, all of you, for being with us, for attending this session. And thank you especially.
Pallavi, if you don't mind, can I ask Satya if she is there just to say a couple of sentences? From Tribute to Life, this is the first webinar we are doing with them. So
thank you, Angie, for staying till the end. I think Dr. Satya left. He was
okay. All right.
He was there till some time, but
we have a lot of international participation. Anna is there from Italy, and Angie was of course there. So I think these webinars will only grow and reach out to a larger audience as we go forward. So thank you very much.
Thank you so much.
Thank you very much. Thank you so much, and have a very good evening and a good Saturday and Sunday.
Thank you so much.
And I hope that we have got that link from Anna, not Anna, from Angie.
She sent the link, yeah.
Okay, thank you.
Thank you so much, everyone. It was a great